let's get started. I'm really delighted to be able to introduce to you Burton Edelstein, who is a
Right the
long-term
first
colleague.
time.
Was it Edelstein?
Right the first time. Thank you.
Okay. So you mean the entire department mispronounces your name?
That's okay. Two of my brothers think they're Edelsteins.
Okay. Good for good bar mitzvahs. Okay, so Burton Edelstein, who is a board certified pediatric dentist with long years of academic experience, author of many chapters and books and peer-reviewed articles, and professor of dental medicine and health policy at our dental school for more than 20 years. But more than his academic leadership, he's had a major impact on advancing the cause of oral health, especially among children, which is a sorely neglected area in American health policy. And he's held a number of positions, which I'm not going to go through because he's going to give us his view of a half a century of activism. But he was the health policy advisor to the Senate Minority Leader. He's been on numerous Institute of Medicine commissions, and he's the professor emeritus of a very important nonprofit agency in Washington, D.C., the Children's Dental Health Project. So I'm very much looking forward to a discussion of the marginalization of dentistry and dental health in our society, and perhaps what we can do about it and what you've done about it.
Thank you. Thank you very much. I very much appreciate this invitation. I want to thank Frank in particular for thinking to ask me to speak with you. I want to acknowledge Doug Chalmers, a good friend while we were gym rats together most mornings at the Columbia Gym, and his introduction of EPIC to me. I've been asked to cover 50 years experience in 45 minutes, which I'm pleased to do. But please feel free to raise questions or ask anything that comes to mind as we go, if you don't want to wait until the end. My viewpoint is rather idiosyncratic. I am an insider on the outside or an outsider on the inside. I'm not sure quite which way that goes, but I have always been engaged actively in my profession, but bringing a different perspective than is traditional. I also want to welcome a couple of folks from the team I continue to work with. I'm now Professor Emeritus from the Dental School and the Public Health School, with my official retirement last June 30th, but continue to work with this team on a number of projects. So I have a number of slides, and the slides are there primarily to keep me moving and keep me on track, but they're not intended for you to read every word. I will try to tell the story as we go. So let's see if I can get that up. And at this point, you should be seeing a slide that says 50 years pursuing oral health for all. Okay, good, good. And so I've kind of summarized the various stages of my career as having been a clinician, a health staffer, an advocate, and for the last 21 years, an academic. I wanted to start with a little context to help get us oriented about the nature of this profession, which I'm representing today. And that is that the first dental school was founded in 1840. And with that, a distinct separation of medicine from dentistry. This has all kinds of implications and ramifications. And the story goes that these two individuals, Horace Hayden and Chapin Harris. Chapin Harris was a student of Horace Hayden and was the second president of the dental school as they were then called. Horace Hayden is said to have studied dentistry with George Washington's dentist, with that famous set of ivory choppers that caused George Washington so much discomfort and pain. But the story goes that Horace Hayden, when he first approached the Baltimore College of Medicine and sought to establish a department that he wished to call oral stomatology, he was rebuffed because dentistry is the child of barber surgeons. And at the time, in the 1840s, there was ever greater attempt to distinguish physicians from surgeons, with Columbia being a real outlier. We'll get to that in just a moment. But the idea that a surgeon would want to establish a department in a medical school was anathema to the medical school. And the story goes that they literally went next door, where the dental school is still located next door to the medical school in Baltimore, and established the first dental school in the United States, the Baltimore College of Dental Surgery. Well, the backstory is this separation of these two professions, physicians and surgeons. They were traditionally very separate. As a matter of fact, the Barber Pole, with its red and white stripes, the original red and white stripes that have turned red, white, and blue, those represented blood or bloodletting or surgery of any kind done by surgeons, and the white for bandages. The standard procedures were bloodletting, dental extractions, as well as grooming services. So being interventionists, if you will, Hippocrates warned physicians not to engage in surgery, to stick to medicine. At Columbia in 1814, the then called Columbia Medical Department, which was the forerunner of its medical school, merged with the New York College of Physicians and Surgeons. That was an interesting college because it incorporated both physicians and surgeons. And the Columbia Vagelos School of P&S, Physicians and Surgeons, continues to retain that name. To the best of my knowledge, we have the only medical school in the country that still recognizes both of the forebears of medicine as we know it today. The consequences of this separation are manifold. Whether we're talking about parallel but different education of the professionals, whether we're talking about workforce with hygienists and assistants that are not analogous to nurses and physician's assistants, although we have something new percolating in dentistry called the dental therapist, which is very much like a physician assistant. The delivery systems are independent. The insurance programs are independent. The professional governance is separate, whether that's professional governance in the way of professional organizations like the American Medical, American Dental Association, or my particular club, the American Academy of Pediatric Dentistry, or whether that is reflected in state practice acts and state boards, where the medical boards are separate from the dental boards. Accountability, who we report to, what we report, what becomes public information about the quality of care delivered, again, completely separate. The cultures are completely different. And certainly this extends over to my domain, which is public health, and public health engagements are very different. For example, the specialty in medicine of public health is called preventive medicine, whereas the specialty in dentistry is dental public health, and they have different orientations and different approaches to population oral health. So there are significant consequences of this separation in terms of the public's health, in terms of what is now becoming ever more prevalent, population health management, where health systems are beginning to think in terms of the entire populations they address rather than individual patients alone, and certainly public policy. And the reason I mention public policy is that public policy governs almost everything on this list. If not public policy, then certainly professional policies impact all of these. So a significant separation. So where are we now? Well, Surgeon General David Sasher in 2000, so now 22 years ago, commissioned the first Surgeon General's report specific to a particular profession entitled Oral Health in America. And his message was very straightforward. Oral health is critical to overall health and well-being. And his catchphrase was, without oral health, you're not healthy. That report has now been updated. It was updated just this year, not as a Surgeon General's report, but as a report out of NIH. There's an important oral systemic physiologic pathologic connection. When you take a look at this picture of the human head bisected, you get a sense of just how much real estate the mouth occupies in the human head, and how it is truly a gateway to respiration, ingestion, digestion, critical for speech, facial expression, critical for nonverbal communication, important for protection. If you put something in your mouth that your body doesn't want, out it goes, as well as sex. So all of these functions are systemic functions. None of them separates the mouth from the rest of the body as the professions have become separated. In particular, periodontal disease is an inflammatory disease. The entire gum surface and support surface for teeth occupies about the same real estate as a human palm. So if you consider your hand and that entire hand inflamed or infected, you can imagine that that would spill over through your circulatory system to affect distant organs. And so it's no surprise that there's relationship between periodontal disease and gynecological and obstetric conditions, cardiac conditions, metabolic conditions, which just is an expression of how the mouth is indeed part of the body. As a nation, we simply do not enjoy oral health. We have a few very prevalent conditions. Caries, tooth decay. 92% of US adults 20 to 64 have or have had active destruction of their teeth through the caries process. Essentially a dietary disease that traditionally by dentistry has been managed as a hygienic disease. Periodontal disease, half of US adults 30 years of age and older experience periodontal disease. Dental oral trauma, 20% of the US population affected. Total tooth loss, 13%, more than 1 in every 10 US adults is completely edentulous. Oral pharyngeal cancer, thankfully, is not prevalent, affecting about 2% of men and less than 1% of women, particularly prevalent in African-American men. But these are the primary diseases. There are also a host of mucosal conditions, developmental conditions like cleft lip, cleft palate, that dentists attend to. But the big ones are caries, periodontal disease, and a little lesser extent, dental trauma. Critically important when we start thinking about oral health versus dental care in a population context, we realize that the epidemiology is absolutely clear. There are tremendous disparities by income, race, minorities, education, immigrant status, tremendous gradients of disparity. And for that reason, I have always represented oral health as a social justice issue, and therefore it is a public policy issue. Well, before we get to my story, I wanted to stop briefly and see if there are any thoughts or reflections about your experience as consumers of dental care or partners with dentists in the work that you do. If there's anything that you feel is important that I failed to mention, or anything that surprised you so far?
I have a question, if you will.
Yes, sir.
You talked about the crucial separation of dentistry and medicine in the United States. Has that been the case in France and Britain and other countries as well?
No, especially in Western Europe and Eastern Europe, as well as Asia. Dentists are generally trained first at the baccalaureate level as physicians, and then elect to pursue dentistry as a specialty. Okay, my story. So I'm very traditionally trained. I was unsure as a young person what profession I wanted to pursue. I have a BA in biology, which is a little bit of an unusual degree. It's a Bachelor of Arts in biology, not science, because Harper College, part of SUNY Binghamton, at the time offered only an arts degree. So that led to study of issues like the historical development of thought in physics, as opposed to a straight out physics course. Graduated in '68, did my dental degree at Buffalo in '72, followed by a general practice residency. Now, residencies are required in only a handful of states, New York and Florida being two, but most states do not require residency. So you can sit for your boards and become licensed to practice dentistry straight out of dental school. But I elected to do a general practice residency, which was heavily oral surgery. So I did a lot of oral surgery at Fort Benning, Georgia, before they assigned me to pediatric dentistry. Prior to my assignment to pediatric dentistry, I had done everything in my power to avoid treating anybody under the age of 20. So it came as quite a shock to both me and the children I treated in the Army to be in charge of pediatric dentistry, but such are the ways of the United States Armed Forces. Having been thrown into pediatric dentistry in the Army, I elected to then pursue a residency thereafter, which took me to public health training. And public health training is what turned my head considerably. So I was doing fine in private practice for 20 years until frustration and disappointment that the care I had been taught to deliver was just not meeting kids' needs. And this is why it wasn't meeting kids' needs. The picture on top is a perfectly healthy dentition of a young child. The picture on bottom is the same level of dental development with a completely destroyed dentition. And this was totally frustrating to me because it was relatively common. As a matter of fact, nationally, about 5% of children under the age of 6 look like that bottom picture. It's consequential. The kids can't sleep, eat, function. It's entirely preventable or suppressible if it's already gotten started. It's dynamic in its etiology. It's resistant to dental repair, and it's absolutely predictive of future cavities unless the underlying disease that causes it is arrested. And this was the great disjunction between what I had been taught and what I found needed to be done. What I had been taught was how to repair this dentition. And here's a picture of the classic dental repair: extractions, crowns, fillings. However, no attention other than lip service to oral hygiene instruction to really addressing the dynamics of the underlying disease. So my personal guideline throughout my entire career has been a quote that has been questionably attributed to Abe Lincoln, which is that it is essential, not optional, but essential to develop a habit to observe and reflect. When I stepped back after a number of years and increasing frustration in practice to observe and reflect, I realized a number of things. Treating the cavities failed to treat the underlying pathology, and that's why these kids continue to have new disease. That Caries is overwhelmingly a dietary, not a hygienic disease. That my education and training did not prepare me to deal with people's decisions about diet. That payment systems wouldn't pay me for helping people modify their diets and bring their kids' disease under control. That simply too many children suffer too much and too often from a disease that's overwhelmingly preventable. That my office was successful in teaching people what they needed to do, but not in helping them. And that children who needed the care most were getting it least, and vice versa. So the whole system was upside down. And this just fed my frustration, leading me to decide to do things a little bit different. So I kept thinking about the basic public health principles that I had learned in my brief, as they say on PBS Nightly News, my brief but spectacular experience in dental public health training. These were the principles that I did not see in practice, going truly upstream to meaningful prevention, allocating available resources according to needs so that the kids with the greatest needs would get the greatest care, leverage passive approaches to health behavior like soda taxes, educate the public, employ population level interventions like community water fluoridation. I'm chagrined that here in Berkshire County, we have not a drop of fluoride in any of our water systems. There are 37 water systems with no fluoride. Seek equity, minimize disability, and most of all, apply science so that you can maximize the utility of science. So the practice successes, well, I went off to Yukon to try to learn more cariology, and we developed a Caries management protocol. So instead of putting those kids in the operating room immediately, we would work with the families to get them into a state of Caries arrest. Worked with the staff to retrain them because hygienists learn a lot about periodontal disease, but almost nothing about caries in their training. So we had to start over with educating ourselves. With parents, needed to reorient them and give them the shocking news that before we fixed the kids' teeth, we wanted to see if we could stop the underlying disease. With partners and associates to monitor care outcomes, conduct clinical research, and report findings. So this is how I first began contributing to the medical and dental literature by doing some small experiments in private practice. And then markedly reduce treatment in the operating room. See if we could get the kids into a state of disease arrest and let them get old enough to tolerate treatment in the dental chair. We did have some significant failures. We couldn't get our payers to pay us. There were no insurance companies and no Medicaid programs interested in paying for disease treatment as opposed to disease repair. My professional association, by which time I had become really active at the local, state, and then national level, was not interested in changing the way that they were thinking about their day-to-day activities. And I worked with a lot of students, but the students had chosen dentistry to be dental surgeons. So this was time for a major career shift. And I thank Jean for mentioning Tom Daschle, who was my boss upon my Robert Wood Johnson Health Policy Fellowship in the US Senate. The interesting thing about that particular year is that as every new Congress, every other year, the Senate and House majority and minority leaders offer up 10 bills, which are essentially agenda setting bills. And Daschle couldn't quite decide if he was interested in a group that was uninsured because they retired early and therefore were not yet eligible for Medicare, or if he was interested in children whose parents made too much money to qualify for the kids for Medicaid, but didn't have the kinds of jobs that offered children as dependents decent coverage. So he was interested in those two populations and finally came down on the side of the children. And so I was assigned this message bill, which turned into, shockingly, because rarely does major legislation pass in a single year, certainly not new health programs, but the Children's Health Insurance Program, and later the Children's Health Insurance Program Reauthorization Act became my responsibility. And they gave the fellow that responsibility because they didn't think it would go anywhere. But indeed, it really did take off. Having left the Senate, I worked with the Department of Health and Human Services on their agency-wide oral health initiative, and then realized that there was a need for somebody other than the organized dentistry to be lobbying on behalf of the population's oral health. So I founded the Children's Dental Health Project in 1997. You will note, because of your sharp eyes, that it did not survive, that it was gone in 2021, just last year. In 2000, I chaired the US Surgeon General's workshop on children's oral health, and then joined Columbia University and served for 5 years on the Federal Medicaid and CHIP Commission that advises Congress and states on Medicaid policy. So this is what this workshop came up with. In brief, expand the dental infrastructure, maximize science, promote prevention, and encourage salutary health behaviors. Looks just like that list that I showed you earlier about public health principles. Well, the Children's Dental Health Project. These 3 children are my favorite children in the entire world, virtual though they may be. Our mission was simply to ensure oral health, wherever you get oral health, for all children by leveraging public policy at both the state and federal level. Our tactic was very straightforward. First, get all kids, well, first, our tactic was to establish pediatric oral health as a bona fide policy issue. Our goal was very straightforward. Get every kid financial access to dental care, and then once every kid had access, then change the content of care to move it toward medical management of the underlying disease, caries. There were opportunities because Medicaid and CHIP were percolating, and Medicaid is always percolating, and CHIP was new, and then in 2010, Obamacare. So Medicaid and CHIP addressed publicly insured kids, Obamacare, privately insured kids. And the outcomes, we did it. We and so many others. We may have been catalytic, but it was many, many groups working together, and especially colleagues at the American Academy of Pediatrics, the Pediatricians Association. We did succeed. So here are some of our successes. The first success was getting pediatric dentistry mentioned explicitly in the federal authorization language that is used to fund training for dentists. As a result, there's been a dramatic increase in pediatric dentistry training, and it's become modal in the population for young children or children of all ages to see pediatric dentists rather than general dentists, especially in major urban areas like New York City. For me, the lessons learned were the real value of being inside the machine, inside the hill, because the hill has been described as a bunch of elected officials supported by a virtual high school class. That is, staff are young. They generally know each other from the work they do. And when they're not dating and marrying each other, they are busy supporting their bosses, and individual person-to-person relationships on the inside are incredibly effective. And so the way this came about was very idiosyncratic. As a pediatric dentist, I went to the staff that was supporting the reauthorization language, explained what pediatric dentistry is, explained that it was a very small, at the time, specialty, but that it was growing, and that it would be great to see if some of the monies could be earmarked for pediatric dentistry. Well, it's a monster that got created because pediatric dentistry was so effective in then lobbying that they have robbed money from general dentistry for this training. Second major achievement was actually somebody else's failure. We worked with many others to stop a change in Medicaid. There was a conservative effort to limit beneficiaries' access to Medicaid benefits, including dental, by adding additional requirements. We succeeded in keeping that from happening. The third one is one that continues to play out, and that is authorization of something called the State Oral Health Workforce Grant Program. And you're probably aware that there are two different types of legislation: authorization and appropriations. This legislation was championed by Russ Feingold and by Susan Collins. It came about because Russ Feingold, a populist, visited every county in Wisconsin every year to host a public hearing on issues of interest to the population. And that particular year, in 2001, actually, he asked about healthcare. At one of his early town meetings, somebody raised dental care. And so at each successive meeting, he noted that he was interested in dental as well as medical care, and was astonished to learn that meeting after meeting after meeting, the discussion centered on oral health and dental care because it was so much more of a problem for his constituents. So he came to the Children's Dental Health Project and he said, give me some ideas of things that states might do if we gave them some money to enhance dental treatment. And we gave him a list of 12 things. To our surprise, the legislation, when drafted, authorized the Secretary of Health and Human Services to allocate funds to any one of those 12 ideas. So short-term lessons learned. Well, what was the outcome? The outcome is that the program continues to exist. It has funded 27 states to date with $132 million to date. Interestingly, both Senators Feingold and Collins, being from rural states, put a heavy emphasis in the legislation on rural support, which was critically important. And the appropriations did not happen for 5 years. So it wasn't until 2007 that monies actually came into the stream. And I need to thank the American Dental Association for lobbying hard to get the appropriations, because the legislation was written to expire if there were no appropriations. So short-term, again, relationships, especially the need to be ready to respond to an opportunity. So when Senator Feingold's office contacted us, within 24 hours, we were able to flesh out a proposed legislative agenda that became the State Oral Health Workforce Program. It has been studied and an evaluation published. It has resulted in higher workforce density and greater access to care, especially in the Midwest and West. Our fourth major achievement was getting a mandatory CHIP benefit. So cycle back to 2000 when CHIP was first enacted. I was not allowed under terms of my fellowship to be recognized as a dentist or as a pediatric dentist. And so while I encouraged inclusion of oral health services, in the end, oral health services, like in adult Medicaid, were authorized only as state options. So each state was given the option of establishing a dental benefit in the Children's Health Insurance Program. That then led to the American Academy of Pediatrics suggesting to me that I stick around in DC and found the Children's Dental Health Project for the sole purpose of trying to get a reauthorization in 2009 to include a mandatory statement on dental benefits. And the way we went about doing that, because initially there were 3 and we grew into a total of 9 people at the Children's Dental Health Project, the way we sought to influence 50 states plus DC to voluntarily adopt a dental benefit in CHIP was by working through national associations of state policymakers, like the National Governors Association, National Conference of State Legislatures, the National Association of State Medicaid Directors, National Association of State CHIP Directors, the Association of State and Territorial Health Officers. We were just a handful of people working with those organizations, and one by one, with Tennessee being the last, in 2009, just before CHIP reauthorization, every state had adopted a dental benefit in CHIP. So we went back to Congress and said, since every state's already done it, why don't you just formalize it in the reauthorization? And of course, we heard that we're not in the business of expanding state mandates, but in the end, they did expand state mandates. So President Obama, on his very first day in office, signed the Children's Health Insurance Program Reauthorization Act that included the dental benefit. Now, I've published the results of this, and the title of the article from Health Affairs pretty much says it all. Medicaid does meet its equal access requirement for dental care. That is, low-income and high-income kids are getting dental care at about the same rates, but oral health disparities remain. And that's because low-income kids are not getting the level of care they need. Fifth major achievement came right on the heels of CHIP. It was the Affordable Care Act. This was the most golden opportunity for pediatric oral health policy. Obama had created this historic opportunity to address delivery, financing, workforce, coverage, accountability, and working with many others. The Children's Dental Health Project led an effort to secure 22 oral health provisions in Obamacare. Now, not all of them have been funded, not all of them have resulted in programs, but there's a complete agenda for how to fix the US healthcare system to incorporate pediatric oral health services and improve pediatric oral health. But the best news is that coming out of the Affordable Care Act, all private insurance programs must include pediatric dental benefits. Lessons learned: dramatic, concerted, responsive, inside the Beltway policy support can achieve major policy goals. Literally the night before the legislation went to the full Senate, we were contacted by the Congressional Budget Office because they had determined that dental costs were greater than anticipated, and they had encouraged the Senate to drop the dental benefit. So it was a rush of active engagement right up to the last minute. But of course, the story never ends because work continues, and we're still trying to get some of those provisions. This is a chart of the various provisions we were able to secure. So do a reality check. Now it's 2021. The mission of Children's Dental Health Project to secure oral health for all, well, we're nowhere near that. The tactic to establish pediatric oral health as a policy issue, that was a success. The goal to secure financial access for all kids, yep, that worked, but boy, did we get in trouble as soon as we started trying to change the content of care. Opportunities, we successfully leveraged public and private insurance, and the outcome was, as you see, the demise of the Children's Dental Health Project. So what happened? Well, we had basically what the image on the upper right shows. We lost our financial support. We had support from the professions, from businesses. We had federal grants. We had contracts with various organizations. We had individual support. We had foundation support. But once we secured financial coverage and started to meddle in what dentists actually do for children in dental practice, all of this, almost all of this, dried up. So why did it dry up? Well, there's the usual. Over time, funders expect grantees, particularly nonprofits, to do more with less, and the cycle slowly starves nonprofits. That's a general finding of small nonprofits. Our success, the sponsors got what they wanted. They got a bigger pie. The professions were happy, more kids were getting care. The dental product industry was happy, they were selling more product. But it was the threat to the status quo that really did us in. We advocated a number of changes. We advocated alternative providers like dental therapists. We advocated alternative payments, start paying for health outcomes rather than only for procedures, as is being done in medicine. We advocated for replacing high-cost, high-profit treatments with low-cost, low-profit prevention and disease management treatments. We argued for practice aggregation, for economies of scale, and we argued for dental integration into larger vertically integrated health systems. So, meanwhile, back at the university, I was brought in by Alan Formicola, and we established what became the section. The College of Dental Medicine is officially at Columbia a department of the medical school. So the departments at the dental school are called sections. So we established the section of population oral health management, which ran from 2000 until my retirement. Upon my retirement, Dean Stoller elected to move the 17 people in the department into the existing clinical departments with the goal of, quote, spreading the wealth. But we have a problem with not having quite enough representation in those departments to be as effective as we may have been when we were an independent department. It was a multidisciplinary research intensive non-clinical department dedicated to the goal of oral health for all. It was the largest public health department amongst the 69 US dental schools. We had primarily non-dentists. We had geriatric, pediatric, and public health dentists, but we had nurse practitioners, physician, health policy people, sociologists, social worker, nutritionists, health educators, health services researchers, people from public health and public policy, healthcare delivery, and community organizing. So it brought many, many different perspectives to the issue of oral health for all. I know I'm short on time, and so I'm going to do a quick run through of what's been going on at the dental school, at least before my retirement. The focus of the work of the department, the section of population oral health, was twofold. Retained a pediatric focus on caries management. Had I been a general dentist or an adult dentist, I probably would have focused on periodontal disease, but trying to move that shift from surgical to medical. And then incorporating dentistry into larger US healthcare systems. Our pride and joy is My Smile Buddy. My Smile Buddy with extensive financial support from NIH and the Centers for Medicare and Medicaid Services, particularly its Innovation Center and private foundations. We developed a completely alternative approach to treating young children at high risk for or with early childhood extensive tooth decay. We have a program where we deliver health education by community health workers in community and home sites. In order to keep the science straight, we have provided them with extensive educational technology. We are targeting families of young children who already have caries experience, and the goal is to arrest disease progression without conventional surgical intervention. So basically, there are three ways of treating caries: surgical, it's immediate, it's gratifying, it's expensive, but it doesn't stop the disease. Pharmacological, it's low cost, it fails to stop disease progression, it's minimally imposing, and it's becoming ever more important, especially in the COVID era when we couldn't bring patients into the dental chair. But then our area of endeavor, behavioral. The pros are that it's low cost, it's painless, it's not imposing, and it does stop disease progression by addressing the root cause. The cons are that it's very challenging to help people achieve behavior change. It takes a long time. These are the various theories this is a model that we based our intervention on, relying on behavior change theories. We were able to implement this with 1,207 children. It was overwhelmingly popular by the parents, and critically important, 57%, nearly approaching 2/3 of these high-risk kids, all of whom were under 6, all of whom had cavities, more than half of them did not have the expected disease progression over the course of a year. So it worked. We then were funded for a randomized control trial. Our first patient was to be seated in March of 2020 when COVID hit, and that was the end of our randomized control trial. We've replaced it with a study of pediatric dentists, dental hygiene educators, and dental payers' views on My Smile Buddy, on the nature of therapeutic caries counseling, on moving from surgical to medical care. And in collaboration with the American Academy of Pediatric Dentistry, we are interviewing 6,000 pediatric dentists, and we're seeking to interview 6,000 pediatric dentists. Our current response rate after about 200 is 31%. On the population oral health management, those same themes I mentioned before: value-based care, accountable care, holistic care that addresses behavior, environment, as well as treatment, integration with medical care systems, and alternative payments. So we now have some very novel curriculum at the dental school. In the first year, before they have a chance to get too ingrained in the mores of the profession, we have a workshop in population oral health management where we stress interprofessional care, non-clinical health determinants, population level needs, alternative payment mechanisms, and delivery system aggregation. And then in the third and fourth years, when they're in the clinics, we have organized each of 4 groups of students as dental management organizations to imitate and mirror the changes going on in the larger dental environment. So circling back to the 1970s, the same clinical frustration that got me started and took me to these various positions continues to motivate current efforts to reform pediatric dental practice, with much work left to be done by my successors. As emeritus professors, we are most interested in our successors, and over the course of the last years, we have trained 58 dental students, pediatric dentists, and general dentists in public health at the Mailman School of Public Health. And I look to them to carry this forward. So crystal ball gazing, where do we think we're going? Despite professional resistance, for example, in the last couple of months, the American Dental Association officially opposed a Medicare dental benefit for people like us. Despite professional resistance, public and corporate policy will continue to push dentistry toward a focus on outcomes, looking at quality of life, self-assessed, and patient satisfaction with care. We're going to see changes in payment that's going to be hybrid, for some payment for procedures, but some payment for value for outcomes. A continued decline in solo and small practices with more and more large corporate dental management organizations. Integration of dental care into accountable care organizations. Attention to social, behavioral, and environmental determinants. And the advent of these dental therapists, somewhat like medical nurse practitioners. So with that, I leave you with a glimpse into what I think the future holds, and welcome any questions, comments, thoughts, or discussion.
Thank you very much. Can you unshare your screen?
Yeah, I'm trying to find that little button. There we go.
Okay.
So thank you for joining me today.
I have a question, and it's interesting because I worked with Tom Daschle on Agent Orange work, and that's how we got the Agent Orange Act passed. He was a very important person for health. Is it the same dynamics of the American Medical Association is less of an opposition now than they were years ago for accountable care organizations and all? Why do you see as the difference between the stronger resistance of the ABA to the AMA?
I think it has to do largely with the fact that a very significant portion of medical care is funded by public programs, specifically Medicare and Medicaid, whereas a small percentage of the dental economy is funded by Medicaid and CHIP. And there's no Medicare dental benefit, sadly. So there's less pressure from government to modify the delivery of services on the dental side than the medical side. But also, people have chosen the dental profession explicitly to be outside of what is changing in medical care. And so there's a cultural bias that is sort of like a parachute being dragged through water, slowing things down. On the other hand, the AMA has a smaller membership of physicians than the American Dental Association has of dentists.
Wow.
And us older dentists are still primarily solo or small group practitioners, see ourselves as business people who provide dental services. And so as dental management organizations expand dramatically, especially hiring new graduates, I think that'll change as well.
Yeah, I guess the modern physician is more of an employee than the dentist, than the dentists are. Yeah. Other questions?
Meredith.
I was wondering, when I went to Columbia Nursing School now 40 years ago, I don't remember a lot of discussion about early intervention with parents about the diet. And because you see these children walking along and they don't drink anything but sodas and sweet stuff, and the food that the families choose to a large degree seems as though it's that the parents don't know any better, very much better. They may sort of know it's good for you to eat fruits and vegetables, but what's available to them cheaply in their neighborhoods is the bad stuff. And how much, therefore, that might be done in schools with nurse practitioners, or coming, whatever the science issues or health discussions in schools could be done now. I'm wondering how that has changed since I was being trained myself, and what you have to say about other people, the nurse there, the dental therapists who are going to be the equivalent of nurse practitioners, and how they can be used for preventive stuff for both parents and children in whatever venues might happen. I mean, that's a very inarticulate way of asking who else is available to help.
The area of greatest interest, if we're serious about changing the dynamics of how dental caries is managed and treated, starts with segmenting the population into the low risk, medium risk, high risk, and really focusing attention on the high risk. The high risk tend to be low income, minority, immigrant, and they are well served. Families of young children are well served by early Head Start and Head Start, by WIC, and by MIECHV, which is the Federal Home Visitation Program. So those three programs all provide in-home or in institutional settings health, education, and, if you will, welfare opportunities for families. WIC has the potential to include dental counseling. It's a nutrition program, and many WIC programs do. MIECHV, the last time we studied that 2 years ago, very few home visitation programs had elected to include oral health counseling. Head Start has a robust oral health component. So critically important is to identify everybody who comes in contact with young families who are at high risk and include oral health counseling. There's a great deal of effort to integrate oral health counseling by pediatricians, but speaking on behalf of my daughter, the primary care pediatrician, So much is being asked of primary care pediatricians that it's difficult for them to incorporate that as well. I kind of blew by My Smile Buddy, but I did want to mention that it was developed with a grant from the Irving Center at the Medical Center, where we brought together 7 or 8 people from totally different disciplines. And we said, if childhood tooth decay had never existed and it showed up like Zika or now like COVID, how would we understand it? Who would treat it? How would we treat it? And that's what led to the development of the My Smile Buddy intervention. The My Smile Buddy intervention focuses on helping people address the very barriers that you mentioned. So the first thing we discovered is that parents were not able to think about or address their kids' oral health when they had housing insecurities, food insecurities, employment insecurities, immigration insecurities. And so we had 13 community health workers, and they were all trained in how to connect people to services for each of those problems. And it was only after they worked with families to address that host of insecurities that they were able to then turn their attention to their kids' oral health. The components of My Smile Buddy are first, engagement and education. Second, risk assessment. Thirdly, goal setting. Fourthly, action planning. And fifthly, support. So it's one thing to set a goal like a New Year's goal, more exercise, better diet, stop smoking, whatever. It's another thing to actually have an action plan. And so in the My Smile Buddy program, the parents themselves write their own action plan. Who is going to do what, when, where, and how, with what resources? And then the program assured that they had the resources. We then stayed with the families for 3 to 12 months, helping them implement their own action plans. And we did that through text messages, through phone calls, through community-based visits, through home-based visits, but we stayed with the families. And there was precious little dropout. I think there was little dropout for a number of reasons. One is that we were helping them address those various insecurities. A second is because we were providing the entire family with the toothpaste, toothbrushes, and suggestions about how to manage diet. And a third was the hand-holding, the attention, the support that the community health workers were more than willing and more than able to provide. In the end, the single predictor of success turned out to be the quality of the community health worker. We had a couple of community health workers who were not nearly as committed to the program and not nearly as effective, and their families did not fare as well. Frank.
Relationships, yeah.
I have a question from a political scientist's point of view. You made it very clear that much of the resistance to the change in the proposed change in the content of dental care comes from your colleagues, the dentists. However, and then when you answered the question that Mary D asked, you talked about how on the medical side, there is all kinds of pressure from federal funding to focus on outcomes, whereas that is not the case in the model of financing and care in other than selected subpopulations. So it therefore seems to me that your natural allies are not the dentists, but they are in fact the doctors and those who fund well-being and preventive care writ large. Your picture at the beginning with the mouth is connected to the gut and is connected to infection and to coronary and other kinds of diseases. Are there studies showing the impact of poor dental health on later stage mental health and the...
Oh, we lost you. Okay, but we got a good chunk of it. So before Frank froze, yes, there's a great deal of work linking oral health to systemic health and thereby raising the public value of oral health and the medical dental integration. But even more so, as dental practices aggregate, as young dentists have a greater interest in, or seem to be having a greater interest in, issues of social justice and employment opportunities in larger organizations like dental management organizations and accountable care organizations, the culture of those organizations begins to infiltrate into dentistry, as does the opportunity. So for example, no small group dental practice or even group of dentists could afford to engage a community health worker or a behavioral nutritionist or a health educator, but a dental management company could. And so if large numbers of practices join dental management organizations, they can look to these management organizations to provide wraparound services that address the underlying etiology of the disease. So there's a lot of tension and pressure and movement that's beginning to bubble up. And we dentistry always follows medicine. So there's been tremendous change in medicine. And now we're looking to see that kind of carry over to the dental side as well.
I mean, there's been notable change in medicine, but I wouldn't use the word tremendous, because prevention is still not in accountable care. Yes, they are getting paid by the outcome, but the average doctor doesn't think, oh, in order to improve my outcome, I better get a nutrition specialist in. So the risk factors that you're describing for dental care are exactly the same risk factors for every other kind of care. And that is not a part of the practice of medicine, except in a very small group. We're still very much specialist driven, and getting reimbursement for preventive care. I mean, COVID was the huge exception, but how many years did it take to finally have mammography to be free? It took about a dozen years of studies to say, well, you know, if you charge a $5 copay, you reduce mammography by about 35%. Yeah. So, but you know, it's not like I have to do something different to take care of my teeth than I have to do to take care of my breasts. You know, it's what happens to school dentists? When I was a kid, used to get yanked out and sent, you know, you had to bring in you still have to bring in dental notes that you went to the dentist. And
in many school systems, the progenitor of the school-based dental services was George Eastman in Rochester, New York, right, of Eastman Kodak. This was his great public gift to the public in Rochester, and they became quite common among school-based health clinics in the U.S. Approximately 20% offer dental services. Heidi has her hand raised.
Can you hear me now?
Yeah. Indeed.
Thank you. A rather pedestrian question. This weekend, I had my grandson visiting, and I watched him brush his teeth, and he has no major problems with his teeth, as I can see. And it was maybe maximum half a minute. And I say, look, you should really brush your teeth for a longer time. It's now suggested 2 minutes. Who says? How can you prove that? And I cannot prove it. And even thinking about it, how did we ever come up with these 2 minutes? You would really need a huge study, have hundreds of people brush their teeth only for 1 minute for a year and the others for 2 minutes, and see whether there's a difference. I mean, how did we ever come up with this 2 minute baseline?
If I could summarize with a single word, artifice. There is no basis.
Yeah.
There is no basis whatsoever. However, there was a major national campaign called Brush 2 times twice a day, 2 minutes twice a day. And it has become normative for people to think that there is some sort of basis for this. In fact, toothbrushing is critically important, but what makes it important is the topical application of a fluoridated toothpaste.
Mhm.
And so when we're dealing with, as Rick McRae, who's joined us, dealt with so much across his career, people with intellectual and developmental disabilities, it becomes more important to get a dab of toothpaste on your finger into the person's mouth to rub around the teeth than it is to try to completely clean the teeth with a toothbrush when that's not possible.
Thank you.
Sort of the extreme case. And Don has a question.
Yeah, two questions. One, does the European healthcare system, do they have accountable care things for dentists? That's the first question. And the second question, as I'm a primary care physician, a medical physician, I know a lot of younger doctors coming in expected to be independent, but going into accountable care organization, it's not the independence that they want.
Right.
I'm very much into the preventive end of it because I was working in public as well as my own private office. But younger doctors are becoming very frustrated with the accountable care organizations that medicine's been pushed in. So first the question, Europeans, do they have it?
On Europe, I'm happy to sidestep the question entirely by saying that I have no idea.
Okay.
And on expectations, increasingly new medical students are expecting to work in the changed environment, whereas new dental students are still expecting to be working in the more traditional environment. I remember when there was quite a tense time at PNS where incoming students' expectations were starting to run up against changes in medical care delivery, such that they were more likely to become employees than independent practitioners. And so PNS hosted a community day to discuss this. And they invited people from the medical insurance world, from the medical delivery world, as well as from medical education. And the message to the students was, the world changed, and you're now going to be overwhelmingly working for others. And when one student raised a question about his debt and said, well, what about all this debt that I expected was going to be ameliorated by independent private entrepreneurial practice? The answer was negotiate hard with your medical system or your ACO to get them to pick up your debt.
Okay. I know that pharmacists are going through the same problem. People going to pharmacy school expected to be independent pharmacists, but because they're being pushed out by the corporate pharmacists, they are now becoming employees of pharmacies, and they're very dissatisfied because they no longer control their work schedule.
Yeah, and in dentistry, the latest figure from the American Dental Association's Health Policy Institute is that 27% of dentists under the age of 30 are now employees working for dental management organizations rather than independent or small group practice associates. So the world is changing. Maybe not as fast as Gene and I would like to see it on the medical side or the dental side, but it is changing. And it's changing toward the sense of accountability. It's hard to estimate how much influence the Affordable Care Act, Obamacare, has had in accelerating change. Despite resistance, it has created significant changes in electronic health records that then make it possible for quality of care assessment and accountability, along with the web, where you have Medicare posting star ratings for hospitals and information on physicians. There's just much more public information available about how to interact with the health system.
Can I ask you an epidemiology question?
I can sidestep it if I need to.
Two questions for kids in rural environments where don't have water systems, but they're drinking well water. Do they have a higher rate of dental caries? And a related question: is there a difference in dental caries among Asian young children, in poor Asian children versus other ethnic groups?
Okay, I'll tackle the first and I'll sidestep the second. In terms of rural areas and private wells, there is quite a mix of natural fluoride across the country, but particularly in the Southwest, extreme levels of fluoride in natural water supplies. Colorado brown stain was the name first given to extreme fluorosis amongst people who were drinking local water in Colorado. And now there's a real effort to adjust the fluoride levels. But if a child does not have access to fluoridated water, then we utilize fluoride supplements, which are not nearly as consistent or effective, but still very helpful. That together with the topical effect of fluoride in toothpastes is a terrific antidote. And now Frederick has a question for us.
Thank you very much for an interesting presentation. I didn't know what to expect when I registered for this program. It was very educational to me. I was kind of amused that you mentioned OBGYN when you were talking about oral health care, since I'm an OBGYN person, and I've never seen the two are related. In my specialty, and Jean mentioned it, how difficult it is to get government to go along with preventive care. And women's health has become like 90% preventive care. If you look at it, it is sort of weeding out the doctors because it's handled by other than physicians. But I think it's a good thing for women because that group tend to get better results when they advocate for women. I appreciate the problem you're going through trying to get kids to come into this. But one of the problems I have, and I just recently retired, just like how you've done so, is that I didn't get any education in nutrition. And the more I look at it, the more I realize that nutrition is universally needed for health. And how do you sort of put this into a curriculum, whether it be dentistry or medicine, because it somewhat requires a radical shift in the way we train doctors.
So let me go back one step about your recognition of a relationship between oral health and birth outcomes. The studies that show that there's a relationship between poor periodontal health amongst pregnant women and unfavorable birth outcomes relates to the spillage of inflammatory markers from the mouth through the circulatory system to then affect the birth environment. And those are the strongest studies amongst the oral systemic connection. In terms of nutrition education, it is my anticipation, my personal idiosyncratic anticipation is that as healthcare providers of all types will increasingly be held accountable for and paid based on health outcomes, there will be greater recognition of the behavioral, including nutrition, environmental, including social and built environment, and genetic with all this hoopla around genomic medicine, contributors to health, and that curricula will increasingly attend to non-clinical aspects or determinants of health, including oral health. So I do note that there are some schools that are now educating, Columbia has always educated its dental students and its medical students together. The first 2 years or now year and a half together. But now we're seeing schools that are combining all of their health professions in a core curriculum that includes nutrition. And I think that's a way to go that would make the most sense. But I agree entirely that the failure to attend to the full range of health determinants has led to further narrowing of health professional practice. Well, I really want to thank you for, sure, David.
Thank you very much. This was just a fabulous talk and very enlightening in so many ways. You mentioned that there was this separation way back between medical schools and dental schools. And it's really too bad that, and I don't know how it is at Columbia now, but that they never got back together, because looking in someone's mouth, the same as looking in someone's feet. In other words, when you look at someone's feet, you can tell, even if they have no complaints about their feet, is this person taking care of themselves? Especially women. If you see a woman they're not taking care of themselves. So that's something that should trigger something in your mind. The same with looking in someone's mouth, that they're generally probably not taking care of themselves. And that falls into the medical realm. Also, fevers of unknown etiology. Rarely do you see workups where someone is looking in someone's mouth. And that's incredibly important, whether it's a brain abscess or whatever it might be, but there's where it can all start. So I think some kind of lecture like you gave, and maybe if you wanted to expand it on a clinical basis, to the medical students, to show them how important the connection really is, I think, would be most helpful, if they can get that relationship going. The other thing is are there databases? In other words, you don't see this in a local dental office, but are they using electronic medical records, dentists?
Yes, so dentists began using electronic records primarily for appointment making and billing.
Right.
But that has expanded, as it did in medicine, to much more robust systems. In terms of my lecturing to the medical students, I look to each of you to help guide me into retirement, because I haven't quite figured out what retirement looks like and how to stop saying yes to too many invitations, which leaves me thanking you for this invitation and letting you know how much I appreciate that you showed up and had an interest in hearing about this.
I'm glad you came out of retirement.
Well, thank you so much for really an excellent presentation, and
well, thank you.
Thank you.
and I have to say that many of us are dismal failures at retirement, so we're probably not good role models.
Well, my goal personally was to meet Frank's expectations. So
Thank you very much. And I just want to say, Burton, that when I was a kid, I was accused of having a dirty mouth, and now I know why.
Thank you very much.